Good morning, everybody. If you wouldn't mind just taking your seats, as they say, and we might move on with the next session. Thanks very much. My name is Caroline Garvan. I'm a Superintending Veterinary Inspector with the Department of Agriculture, Food and Marine, and I'm delighted to be here today to chair what is truly a One Health session. We have speakers from human health, animal health and the environment. So we will kick off with the human health side. And our first presenter is Dr. Kieran Walsh. Kieran is a Senior Health Technology Assessment Analyst working with the Health Information and Quality Authority. He's previously worked on COVID-19 evidence synthesis, and he's here today in relation to evidence synthesis in relation to AMR. And what Kieran's going to present on today is a really interesting study that was commissioned in 2019 by the Department of Health, and it looks at something we're all interested in, economics. It looks at the economic burden of antimicrobial resistance, in particular in the Irish public health system. And in iNap 1, we had a particular reference to the burden, the economic burden in the EU of 7 billion per year estimated cost of lost productivity. So Kieran's going to talk to us today about the report findings in the Irish setting.
Good morning, everyone. I'm delighted to be here with my colleague, Dr. Patricia Harrington. Today we're going to present you some of our work that we in HIQA have done to inform policymaking in the area of AMR under iNap 1. Okay, so just by means of overview, I'll first give you a bit of background into the project that we did. I'm then going to discuss in detail the economic burden of AMR study that we conducted. I'll then hand you over to my colleague Trish, who will discuss the findings of another project, HIQA of C-reactive protein point-of-care testing. And finally, we have some, comments on the relevance of our work for iNap 2. Okay, so as we all know, AMR is a significant issue. It is a global public health concern. Rising rates of AMR will make it increasingly difficult and expensive to treat and control infections, and it could affect the sustainability of some modern healthcare interventions. The financial cost of treating resistant infections places a significant burden on healthcare systems and on society at large. There is significant international evidence of this. So a recent Lancet publication estimated that globally there were nearly 5 million deaths associated with bacterial AMR in 2019, including 1.27 million deaths directly attributable to it. The OECD in 2018 estimated that around 2.4 million individuals could die due to AMR in Europe, North America and Australia between 2015 and 2050, and that treating it could cost healthcare systems up to $3.5 billion per year. The seminal O'Neill report, which I'm sure a lot of us are quite familiar with, estimated that globally by 2050, 10 million lives a year and a cumulative $100 trillion of economic output are at risk due to AMR. So, while we see there is, across all reports, there is substantial variation in the estimated clinical and economic impact. However, there is consensus that AMR is a significant issue and will only get worse if measures are implemented now. So just in terms of the background to the particular project we're talking about today, so in the context of iNap 1, HIQA was requested to undertake 2 discrete projects. The one I'm going to talk about is the economic burden of antimicrobial resistance and analysis of additional costs associated with resistant infections. And the second project is HIQA of C-reactive protein point-of-care testing to guide antibiotic prescribing for acute respiratory infections in primary care. So this project was conducted, it was started pre-pandemic, but it was completed during 2020 and 2021 and was published July of last year. The purpose of the study was to estimate the current costs associated with selected antimicrobial resistant microorganisms of public health concern in the public acute hospital setting in Ireland. We focused on 8 specific pathogens of concern. Why we focus on these particular 8 is because we knew that there is good surveillance data, high quality surveillance data on these particular resistant strains in Ireland. And the objectives of the project really were twofold. First was to review the methodologies used in costing AMR in general and in discrete pathogen-specific AMR outbreaks. And secondly, and that was research question 1, the second research question then was to develop and apply a methodology for estimating current health services costs associated with AMR in Ireland. So So just to highlight the overarching approach, there was a rapid review of methodological approaches, looking at how methodologically how other researchers costed AMR, and this informed our economic analysis in part 2. And throughout, we were fortunate to have an expert advisory group involved, and this comprised patient involvement, clinicians, policymakers, and other service providers. So what were our findings? So RQ1, which was the literature review, 27 studies were found, 9 estimated the cost of outbreaks, generally in ward or single hospitals, and 17 estimated costs at a more larger, kind of broader population level, and 1 estimated the cost of both. Our take-home really from the literature review was that there is no gold standard approach to costing AMR. It's a very challenging exercise, and it's very much dependent on the quality and type of data that is available. And as a consequence, cost estimates vary substantially from study to study. We noted that particularly these outbreak studies, they were required particularly extensive local data. So they included a range of, and it varied a lot, direct and indirect costs. So they might, direct costs might include staffing costs, PPE, diagnostic testing, and then your indirect is kind of your loss of revenue due to cancelled procedures and so on. And I suppose from our perspective, during the pandemic, we knew that collection of such data would present feasibility issues, particularly because we don't have currently in Ireland a centralised healthcare cost centre or model of healthcare costs. So these things are very tricky to collect. And in terms of informing the next step of our project, there was a study conducted by the OECD. It's a high-quality population modelling study, and so they use EARSnet data, which is a European AMR surveillance, focused on antimicrobial resistant pathogens, and they also use a burden disease analysis, which had been previously developed by the European Centre for Disease Prevention and Control. So we knew that by adapting this approach, it would allow a standardised approach, enabling cross-country comparisons and maybe comparisons over time. So just at a high level here is the methodological approach we use for RQ2. So there's 2 main parts. First was the burden of disease analysis, and the second was the economic analysis itself. So the inputs to the burden of disease model was the Irish EARSnet data obtained from the HPSC, and the outputs of that then were the AMR incidence and attributable length of stay, and then also attributable disability adjusted life years and mortality. So the Gallie is a utility measure commonly used in burden of disease studies. It refers to the loss of healthy years of life. So what we did is we combined the quantitative measures, so the Gallies and mortalities, with some of the qualitative evidence from literature to describe narratively the burden of disease in patients in one part of the report. So going back to the economic aspect, we combined the inpatient bed day costs along with the quantitative AMR instance and attributable length of stay. And from this, we were able to estimate the expected total additional costs for treating a resistant infection relative to susceptible infection in terms of excess bed days in public acute hospitals in Ireland. So what did we find? So the total number of resistant infections across all public acute hospitals in 2019 was estimated to be over 4,700, which resulted in an expected total additional cost relating to excess length of stay of 12 million euros relative to susceptible infections. There's quite a large degree of uncertainty here, largely driven by uncertainty in the instance of infections. So these resistant infections account for approximately 215 attributable deaths and nearly 5,000 disability adjusted life years, or years of healthy life lost. The burden of disease was found to be highest in males and in infants and older adults. I suppose there are important limitations with this study that we have to acknowledge. So models are simplifications of complex systems and rely heavily on the underpinning data and assumptions. And as we know, AMR is a very complex phenomenon, so some of the models may have oversimplified the clinical sequelae. There are also a limited number of included pathogens and costs considered due to data constraints, and this will likely lead to an underestimate of the cost of the totality of AMR. And finally, the substantial additional costs associated with outbreaks were not estimated. So as we know, outbreaks can be quite disruptive at a systems level, and it was not possible to do that given the data that we had access to. So it's certainly something that we would like to look into going forward. So I'm just going to pause it there, and I'll happily take any questions at the break. But thank you very much.
Thanks very much, Kieran. And we won't be taking questions during this session, but there is always opportunity at lunchtime to catch up with any of the speakers. So our next speaker that I'd like to welcome is Dr. Patricia Harrington. Patricia is a Deputy Director within the Health Technology Assessment in HIQA. She has extensive experience in evidence synthesis, and today she's going to talk to us, I suppose, about near-patient testing. And I mean, it was identified as a priority in iNap 1. It's certainly something we use in the veterinary side in terms of pen-side testing. Rapid diagnostics is recognised as a key deliverable at EU level. So I suppose it's really interesting today to hear from Patricia and how these kind of tools can guide better prescribing practices.
Okay. So this particular HTA obviously had quite a lot of acronyms associated with it. So it was a technology assessment of C-reactive protein for point-of-care testing. So as I say, it was one of the ones that calms nightmare and to say in terms of the number of acronyms that we used throughout the report. The particular project was following a formal request from the primary care lead in the HSE, and that was subsequently endorsed by the Department of Health. And completion of the project was consistent with two of the strategic objectives identified under iNap 1. So the aim of the particular assessment that we did here was to establish clinical and economic impact of providing point-of-care testing to inform prescribing of antibiotics for patients presenting with symptoms of acute respiratory tract infections in primary care. It was a full HTA that we did, so it included also then as part of that we would have considered the organisational, ethical and social implications of implementing point-of-care testings, both for the patients, the general public and the broader healthcare system. And I suppose the main thing to consider in relation to this is the population that of our interest were those presenting with symptoms of acute respiratory tract infection in the primary care system, and it's in the context of where there's clinical uncertainty regarding the presence of a serious bacterial infection. So with C-reactive protein, it's a protein produced by the liver. Typically you may see elevated levels in response to bacterial infection, but less so in respect to a viral infection. So it helps to discriminate between the two. So where there's clinical uncertainty for a clinician as to whether or not a patient may benefit from an antibiotic, there may be a role in the use of C-reactive protein testing to guide, as I say, the use of an antibiotic. So in terms of some of our key findings of the report, obviously one of the items was in relation to the frequency of respiratory tract infections as a presenting complaint within the general practice setting. So they accounted for about 23% of general practice consultations in Ireland. We know that obviously most respiratory tract infections are viral and they're mostly self-limiting, but obviously a small number of them are bacterial. But even within those then, the majority, a strategy of no antibiotic prescribing or delayed antibiotic prescribing is generally appropriate. But clearly antibiotics are indicated in patients with a diagnosis of pneumonia and those with lower respiratory tract infections. So as we've heard earlier this morning then, overprescribing antibiotics for respiratory tract infections in Ireland it's common. It's common in industrialised countries, and it is also then that we have this issue of antimicrobial resistance being driven by excessive and inappropriate antibiotic prescribing. And prescribing antibiotics is not without other consequences, even at the patient level, which is that 1 in 5 may experience mild self-limiting adverse events associated with the prescription. So in terms of what the work we did, one of the items was then, it was a systematic review to look at the use of C-reactive protein point-of-care testing to inform antibiotic prescribing in primary care. And based on the findings of that review, it was seen that across those studies that there's approximately can lead to a reduction of about 24% reduction in antibiotic prescribing in patients with upper and lower respiratory tract infections. We saw similar results for upper and lower respiratory tract infections, but there was substantial heterogeneity across the trials that were included. And specifically then, there was very limited data in the context of its use in children. In the context, we didn't find any studies in the context of long-term care facilities or in out-of-hours clinics, where obviously we know a large percentage of prescribing for these conditions arises. And also the other issue was that the data were based on short-term follow-up data of about 3 months within the trials. So it's uncertain that a continued use of this is, as I say, as a decision support tool as to its effectiveness in the longer-term setting. It didn't lead, use of the C-reactive point-of-care testing doesn't lead to an increase in adverse events for the patients. So there isn't an increase in duration to improvement in the risk of reconsultations or patients ending up being rehospitalized or being hospitalized. But what we do know in the context of point-of-care testing, it's probably been very significant over the course of the pandemic, is when you're looking at huge amounts of additional testing, point-of-care testing that have happened in the context of COVID, is that the accuracy and the precision of the validity of the results that you're going to get is going to depend on the overall quality assurance of a system to ensure that staff are trained to use it, so that the results that you're actually getting from the test are actually valid and appropriate for use. So I suppose in previous findings it has been found to be cost effective as an adjunct. We've developed an economic model in relation to this to look to see whether what was impact was likely to be in Ireland. While they were found to be more costly than usual care, it was estimated that it would lead to reductions in antibiotic prescribing in the community. So in the context of that, we estimated about 1.3 million tests that might need to be carried out in the context of a year, but that could lead to a reduction in antimicrobial prescribing for respiratory tract infections from 2.4 to 1.8 million if it is just the C-reactive protein testing without a communication skills training for GPs, but that could reduce to 1.2 million prescriptions in the context of roughly a 50% reduction if it was in the context also of enhanced communication training. So I'm just going to skip on a little bit here then. So there is a question then about obviously how this model would be funded, as to the extent to whether it would be, devices would be provided to each GP practice, and that had implications obviously for the budget impact of implementing the intervention. It was estimated that it was in place with including communication training, it would lead to an estimated saving of about $1 million over 5 years relative to usual care. But there is substantial variation in the estimates of the cost, depending on, as I say, whether devices were provided per GP, per practice, and also whether or not a fee-for-service item was going to be used in the context of it. So we did also recognise that, from a GP's perspective, it can displace clinical activity because it takes time to perform these tests. We've seen this similarly also in the context of COVID, in terms of that it's, that it can disrupt. So I'm just going to skip here to the main advice out of this in relation to it, and because I think it's still relevant in the context of the information that we've had, with the pandemic happening since this particular project was undertaken, which is that point-of-care testing could be considered in the context of a suite of interventions. So we've seen a lot of the other interventions that have been put in place by the AMRIC teams and the IPC measures that have been put in place, that it may be a useful intervention to include on top of that to improve antimicrobial stewardship. That there is uncertainty in relation to it, and particularly long-term sustainability of it, because it's mostly based on short-term trials, but that it is carefully monitored, and a carefully managed and monitored pilot programme may be appropriate. And I think that from what we're seeing in terms of some of that other prescribing data from the long-term care setting, that it may support, along with those other tools that have been put in place, that it may support antimicrobial prescribing and a reduction in inappropriate antimicrobial prescribing. I think you may all have been familiar with the iNap 2 actions, so there are a number of those, and actually that was, as I say, it was a finding from the original report, is that consideration of potentially undertaking a pilot project in relation to it, and I think that has actually been included as an action for the HSE out of iNap 2, and obviously there is a requirement, or there is other actions that were included in relation to the potential use of other, I suppose, point-of-care testing to support prescribing and to support a reduction in inappropriate prescribing and to help in terms of managing, in terms of antimicrobial resistance. So thank you very much.
Thanks very much, Patricia. And now we're going to move over into the animal health side of the house, and I'm delighted to welcome Dr. Simon Doherty here from Belfast. Simon is a senior lecturer in the Animal Health and Welfare School of Biological Sciences at the Institute of Global Food Security in Queen's. Simon is a vet by trade. He was president of the British Veterinary Association in 2018 to 2019. He was supposed to present for us last year at our Animal Health AMR Awareness Week and was struck down with COVID. And he sent us an email to say he was on his way into hospital, but that he had found another speaker. So we very much appreciated that. Last week he was in the House of Lords discussing the sustainability agenda, and in particular the role of the veterinary community. So I think it's very pertinent today that he's here to talk about One Health. and how the One Health principles can be applied in agriculture. Thanks, Simon.
Thanks very much, Caroline. And, I'd like to start off by congratulating both DAFM and the Department of Health for everything that they have achieved through iNap 1 and everything that they are setting out to achieve in iNap 2. It's really impressive. A lot of the themes that I'm going to talk about in the next half an hour or so have already kind of come out this morning. We're talking about communication, we're talking about collaboration, we're talking about data. We're talking about measuring, benchmarking, and then setting targets. But as we come out of COVID, I don't think we've ever been in a position where we can have these conversations with the general public than we ever could before. We're really in a remarkable situation. R0 was being reported on the news at 10 every night. All of a sudden there's an awareness of what herd immunity actually means in relation to both public health and in relation to animal health. Some of what I'm going to present here today is Queen's University content, and some of it is Vet Sustain, and I'll talk a little bit about that. Some of it's from my role in BVA, and I'll touch a little bit on our wider role within the Federation of Veterinarians of Europe, and I've got one slide then relating to the British Cattle Veterinary Association. But again, it's about collaboration. One Health is about collaboration. So there are lots and lots of reports, and I think it is important that both in terms of a national context and in terms of a continental context, okay, we might have Brexited, but we're still within Europe, and funnily enough, animal health and human health don't necessarily respect the border at Newry or at Strabane. So we have to very much be keeping an eye on that. So linking things, from some of the work that DAFM has been doing to the farm to fork strategy at European level, I think it remains very important. And certainly in my role within the Federation of Veterinarians of Europe, it certainly remains top of the pile. I love this little short definition of sustainability, and I think in particular in relation to food production, it's very, very pertinent. Enough. Okay, we need to reduce food waste, we need to maybe produce a bit more, but we don't need to produce a huge amount more. We need to look at where we are producing the food and how we're distributing it. So there's a piece there around enough in terms of feeding 9.8 billion people by 2050. For all, okay, that's bringing in the equity piece. There's a real equity piece around sustainable food production and around One Health. And then the forever bit is, whether that we're talking about sustainability in economic terms or whether we're talking about it in environmental terms, we need to be leaving something behind for future generations. Okay, so we either need to be leaving sustainable farm businesses behind, we need to be leaving sustainable health systems behind, or we need to be leaving sustainable food production behind. So talking then a little bit about One Health, and there's a lot of these, One Health and sustainability are real kind of buzzwords at the minute. They're kind of all out there, and some people sort of think, is One Health this kind of slightly ethereal idea of people, animals, and the environment. Well, yeah, so what? Okay, or sustainability. Well, it's kind of out there. But our farmers are starting to get the grip on this, okay? They're focused now on net zero like they never were before, and we need to be encouraging that momentum to build up, both in terms of what you've heard, some of what you've heard already about productivity and environmental aspects, but also the economic aspects as well. But the important thing for me about One Health is that it is about transdisciplinary and interdisciplinary collaboration, and that is what an event like today is absolutely all about. Martin stole my thunder in talking about Hippocrates. So if you want to learn about the health of a population, look at the air they breathe, the water they drink, and the places that they live. One Health is not a new concept. This link between people, animals, and the environment goes right back several millennia. Pasteur, I don't think I'm the only person who thinks that this looks a bit like Luke Skywalker, but Pasteur, linked medicine and veterinary medicine. He recognized that without understanding anything about rhabdoviruses, he knew that there was something in passaging something in a rabbit and taking desiccated nerve tissue and injecting it into a small boy that he could save them from rabies after they'd been bitten by a rabid dog. So there is something there about that link between medicine and veterinary medicine that goes back hundreds of years. Virchow, this guy is, and I put this sort of quote, between animal and human medicine there are no dividing lines, nor should there be. And he absolutely was the father of modern pathology. This is the guy who described thrombosis, embolism, leukemia. He was a big advocate for systemic autopsies. In terms of meat hygiene, he did work on trichinella. And in terms of understanding the social science aspects of disease, he knew that there was a piece in and around typhus, which needed to be addressed, as well as the kind of scientific aspects. And then fast forward to Calvin Schwab, and Calvin was the first guy to really coin the term one medicine. This chap was made a joint appointment at the University of California, Davis, in both the medical school and the veterinary school around epidemiology, the study of the spread of disease. Calvin, as I say, that concept of one medicine now has really evolved over sort of 40 or 50 years into what we now think of in terms of One Health. It's really interesting. In terms of sustainability and One Health, people love this kind of idea of, can we talk about definitions? We love a definition of One Health. And so anyway, this is the definition that I sign up to. Collaborative, multi-sectoral, transdisciplinary approach, working at local, regional, national and global levels to achieve optimal health and well-being outcomes, recognizing the interconnection between people, animals, plants and their shared environment. Okay, so we've got people, animals, plants, and their shared environment in there. But it is very much about that cross-discipline working. And again, that's what's coming out today. It's about looking at the different levels, okay? Whether that's at individual GP practice level or individual farm level, right up to what we're doing in Europe or what we're doing with WHOA, and the World Health Organization at global level. It is looking at all of those levels. And I think while there are some people who like to sort of slice off one welfare as a kind of piece, I think there is a general acceptance that one welfare is kind of what part of One Health. We're really, if we were going back to reinvent it again, we might talk about one well-being as a product of health and welfare. This infographic from Sweden, I think, is quite a useful one because, for those that like to sort of say, well, is that not just veterinary public health, or is that not just about public health? This kind of helps to sort of break it apart and put it back together again and look at where all the disciplines are within One Health. But again, it's not just about all of those individual disciplines working in isolation. It is about them working collaboratively and getting that cross-disciplinary, interdisciplinary collaboration and communication going. So, drop out One Health and slot in One Agriculture, and we can kind of start thinking about the same things. And in many ways, what we do at the Institute of Global Food Security at Queen's is kind of One Agriculture, because we're bringing together human nutritionalists, we're bringing in environmental scientists, we're bringing in agronomists and agricultural scientists. We've got a few of us are vets, but we're kind of bringing that whole piece of people, animals, plants, their shared environment together. And then thinking about it in terms of the social science and in terms of the different disciplines that are going to help us to really make progress with sustainable health systems. I hate people that put up slides that say, I know you can't read this, but this is hopefully the only one. But the bit that I've highlighted there is really kind of pulling out this piece from this EMA and EFSA joint report. Now, it's gone back to 2016 now. But it's really kind of picking out that piece around improved animal husbandry systems as a way of helping to reduce antimicrobial usage. And you'll hear from the next speaker probably a bit more about that specifically. But there has been a huge amount of work done, obviously, in this area. Dame Sally Davies, this is our former Chief Medical Officer, was, I think, very sceptical about, she had this impression when she first took on the role around AMR of farmers and vets doing kind of a bit of bucket chemistry out on farm, and it was a huge amount of antibiotics being used. But I think she recognises now that we appreciate that good farm management, biosecurity and animal husbandry systems are vital to minimise the occurrence of disease and therefore reduce the need for antibiotic usage. There is a bit of this that is back to basics animal husbandry. And if you think about some of the recent concepts, I don't know how many vets and agronomists we have in the room, but things like cow signals, which is an approach which originated in the Netherlands, is kind of back to basics animal husbandry. And it's looking then at sustainability framed around good old back to basics animal husbandry in some ways. So I said I would touch on some of the work that BVA did. BVA has been involved with RUMA, the Responsible Use of Medicines and Agriculture Alliance. I think that within the context of what we've done with RUMA, it's been industry-led. It's brought together all of the relative stakeholders around responsible use. And you heard from the Minister this morning that we're looking at prudent use. Yes, we're looking at setting some targets around sales and ideally around use, and that'll lead us on then into doing some benchmarking and target setting in order to reduce the amount of antibiotics we're using. But it is about prudent or responsible use of antibiotics. We still want to have access to antibiotics where we need them and where we can best use them. But ideally, taking things like biosecurity and preventative medicine approaches is going to be more sustainable in the long run. But through Vet Futures, which is an initiative between BVA, which is our representative body, and the Royal College of Veterinary Surgeons, which is our regulatory body, we were kind of looking at what the vet profession would look like in the UK, sort of towards 2030 and beyond. And two of the key outcomes of that then were our animal welfare strategy and our One Health in Action report. And part of the reason for pulling together the One Health in Action report was to look at where, bringing together the relative One Health stakeholders, which incidentally, I'm not sure that, I think dentists have been mentioned today, but we brought dentists as well as nurses and medics. You can see there, Veterinary Public Health Association, British Veterinary Nursing Association, and from the environmental side, we brought the Wildlife Trust and the National Trust on board. We took some of the activities of these groups working together and we produced the One Health in Action report in order to showcase some areas, including antimicrobial resistance, where by bringing those relative stakeholders together, they can make a real difference. And certainly some fantastic work between the Royal College of Nursing and British Veterinary Nursing Association. British Dental Association were doing a huge amount in respect to their reduction of antibiotic usage before COVID. Unfortunately, it's gone back up during COVID, but I think that is the same all over. But again, it was to stimulate some of the collaboration around that. And there's been some really interesting work around passive smoking campaigns and access to green spaces and social prescribing. There's been some really good work, particularly in those areas over the last couple of years. As well as around antimicrobial use and antimicrobial resistance. BVA produced a sustainable animal agriculture position, and again there was a focus there on preventative medicine, herd health planning, routine visits, biosecurity, but there is a line that you'll see in there which is around benchmarking tools to monitor and reduce antibiotic use. Okay, so again that fed into our work with RUMA in that respect. We produced some campaign material. You can see the poster on the right, Are You Antibiotic Aware? And similar to some of the campaigns that have been happening here, just in relation to, do you actually need antibiotics? And that applies as much to animals as it does then to human beings when they go to the GP practice as well. And that 7-point plan was for the sort of back of the door in the veterinary practice, just again to get practice staff, vet nurses and vets just thinking about, their, I suppose they're, in some ways, they're red antibiotics and they're green antibiotics in some ways. Before we Brexited, we were part of European Antibiotic Awareness Day, and again, we did some of these kind of little infographics. There's 6 of them there. I'm happy to share them. But those little infographics, around sort of myth busting, around the use of antibiotics, which were equally as applicable for animal health and human health. And some, again, just some other resources then for vets and to start having conversations with farmers. I think, one of the big, examples of really where we've been able to make a huge difference in the last sort of 15, 20 years, I suppose, maybe a little bit longer, is around the use of selective dry cow therapy. So combining some diagnostics in terms of looking at cell counts. So when cows come towards the end of lactation, we take a cell count, a somatic cell count. If they're over 200,000, they get an antibiotic dry cow therapy treatment. If they're less than 200,000, they get a teat sealant. And that has made a huge impact, actually, in reducing the amount of antibiotics that are being used in the dairy herd, rather than just blanket treating all 4 quarters in every single cow with long-acting antibiotics when they get to the end of their lactation. So, again, but there was a real communication piece there, in terms of getting farmers and vets on board with that. And to a certain extent, we're still on that journey, but we've made a huge impact in that respect. The farm quality assurance schemes, again, part of this is about communicating to the public. And, if you go to somewhere like the States, there's all chat about, 0 antibiotics. We don't use any antibiotics at all. Well, it's a bit of a misnomer. In theory, by the time food arrives on the table in the UK or Ireland, it shouldn't have any antibiotics in it either, because of withdrawal periods and because of the testing that we have in place in that respect. But the farm quality assurance schemes add a level of, protection in there around responsible use of antibiotics and extra checks on medicine records and usage and so on. Now, that's not to say that it's always perfect. There will always be a few bad apples in the basket, and certainly for us as vets, we want to work in terms of moving that forward. Social science has already been mentioned. Actually having some understanding of what vets and farmers and pet owners, for that matter, understand around antibiotic use is, and some of the human work in Ireland was presented earlier on about those attitudes and understanding that. Because if we can understand some of those attitudes, then we can use appropriate methods for continuing to change some of those behaviours and some of those attitudes. This is Alison Bard. Alison did her PhD really on the social science aspect. She was at the University of Bristol, and again, predominantly on the dairy side, but used the technique of motivational interviewing to work with farmers to help them and through their vets to understand more about responsible antibiotic usage and start thinking about changing some of those behaviours. So having some of those social science tools in the toolbox now are really important, again, on the human side and on the animal health side. A few other innovations with our PIG electronic medicines book. We have a company, one of my colleagues in Northern Ireland left general practice and set up Vet Impress, which is a company which was really designed to have a platform that would bring data together from all sorts of different sources, including antibiotic usage at sort of vet and farm level. So there's a lot of innovation going on there. And certainly we need to be able to look at where the challenges are, where the possible solutions are, and then look at where there are successes and, in championing some of those successes. Vet Impress was subsequently bought out by one of the major European veterinary pharmaceutical companies, which again just demonstrates the level of commitment that started off as a bunch of vets working in Northern Ireland with a good idea, and it became something that is now available globally as a platform for benchmarking the use of medicines on our farms, and then setting targets and moving forward from there. I said I mentioned FVE. So all of the national organisations, we had the FVE General Assembly / COVID melting pot in London last week. Yeah, I mean, you can see there that I chaired the Food Safety and Sustainability Working Group at FVE. We produced a paper, which is on the right-hand side there, about vets committing to sustainable food systems. And absolutely part of that is in relation to antimicrobial resistance. Now, if you think back to the start, I said we, vets, cannot do One Health on our own. It's about transdisciplinary, interdisciplinary collaboration. So the Federation of Veterinarians of Europe is working very closely with other allied environmental and human medical bodies across Europe and sharing some of this information and communication as well. Very quickly on the Vet Sustain, so One Health I see as part of the journey towards sustainability. So if you think about that, Newcastle University, enough for all forever, you know, that's almost kind of the end point. That's where we want to reach. How do we get there? We can get there using a One Health approach. Okay, so if we work collaboratively together on that journey, we can work towards sustainability. So Vet Sustain, we established about 4 years ago now. It's registered in Scotland. And it was a group of us who recognised that BVA could only do so much with the resources that they had. We set Vet Sustain up as a community interest company, primarily looking then at sustainability within the veterinary sector. SDGs have already been mentioned today. We wanted to contextualise this a little bit for you know, the UK and European veterinary sectors. So we produced 6 veterinary sustainability goals: diverse and abundant wildlife, net zero warming, no waste society, a good life for animals, so bringing in the modern terminology around animal welfare science, health and happiness, both of the animals and of the vets and of their owners. Okay, so those owners could be pet owners, it could be farmers or others, and enough clean water for all. It was felt that it was absolutely essential that we maintain water in there because it's going to be really important going forwards. We've got 4 working groups. You can see there the food and farming working group who are doing a huge amount, and there was some discussion already about webinars. Again, we've done a lot of online training, and we're about to launch a Lantra accredited package for farmers and farm vets in and around sustainability in the farm setting, but also then feeding into companion animals and so on as well, the veterinary curriculum and communications and engagement. Veterinary practice checklist, and again, you know, linking this back between us as medical professionals and what we can potentially share, you know, with the wider community. We've got a piece in there. No, it's not going to show up on the screen. A piece in there around using medicines responsibly. So again, looking at how, both in terms of antimicrobials and antibiotics, but also things like antiparasitic treatments, which there's a huge focus on at the minute within the veterinary profession around sustainable use of antiparasitic products. BCVA, again, you know, produced a sustainability paper specifically for farm vets working with cattle, but again, very much sort of focused on taking some of those general approaches of One Health and sustainability and focusing them then for cattle vets. Bit more online training. So again, this is also Lantra approved, but NOAA is the National Office of Animal Health. It's our body that sort of represents the animal health sector, have produced these animal medicines best practice, and again, those resources are also available in terms of helping to improve the narrative around the use of antimicrobials. In terms of then of affecting change, look, nothing beats what the farmer down the road has said, and you know, and that applies in Ireland, applies in the UK, it applies in Europe. I've visited farms all over the world, and the best way to communicate with farmers is to get another farmer to chat with them, they learn more at the market than they do at the best of intentions veterinary practice meeting or from a rep. But having those meetings where we can encourage discussion amongst farmers with their vets, doing some benchmarking and actually getting out on farm and understanding how these things work in practice is really, really important. And it's, from a social science aspect, it's a critical way for learning. In the same way, it's also important, we've got a lot of the sort of open farm days and things now. It is really important that we encourage the general public to get out on farm and understand what farming is about and how it works. And I think there's a lot to be said for initiatives like that in helping to communicate animal health and welfare generally, but also to get some of that discussion going around things like the use of antibiotics, because there are lots of misconceptions out there that vets and farmers are using loads of antibiotics, and that's not necessarily the case. Unashamed plug, I don't get any royalties from this book at all, but we probably win some kind of prize for having the biggest number of co-authors in one chapter. But I bring this to your attention because it's not a particularly expensive book, and I would encourage you to kind of look at this sort of one welfare in practice. We've written this chapter on sustainability and the role of vets in aligning animal, human, and environmental well-being, because I think in terms of that sort of One Health narrative that we're talking about here today, there's certainly a bit to be played out there. So I would encourage you to, anybody that's interested to try and get a hold of that book. I'm going to leave you with this thought, okay? And O'Neill has been quoted in several times today, but at the end, in the conclusions of the O'Neill report, he says, although AMR is a massive challenge, it is one that I believe is well within our ability to tackle effectively. It's up to the people in this room and the people that are watching this online to get the finger out and get behind iNap 2 and really make a difference. You've made a huge amount of progress through iNap 1, and I would encourage you to build on that momentum as you move into the next phase. Keep One Health in mind. Keep that transdisciplinary, interdisciplinary collaboration in mind, and I wish you all the very best. Just want to acknowledge, Queen's, BVA, Vet Sustain, and some of the other organisations that I've talked about today. And I'm very happy if anybody wants to get in contact either after the meeting or over lunch. Okay, thank you.
Thanks very much, Simon, for that really stimulating and motivating presentation. And now we're moving on, and I suppose we're building now on the collaborative theme. Our next two speakers are presenting a joint presentation. It focuses primarily on the pig sector, because it's fair to say that the pig sector tends to, in all countries, come under a lot of scrutiny because of their production systems. So our first speaker is going to be Mr. Paul Spillane. Paul is a vet specialising in pig practice for the last 25 years plus. And I suppose he's going to talk to us about the interventions he has introduced both on this farm and on others. And in particular, he has a keen interest in health monitoring and evidence-based decision making. He also very much supports the relationship building, the one farmer, one vet relationship. So I'll just call on Paul now to come up, please.
Thank you, Caroline, for the introduction, and good afternoon, everybody. So, actions to address antimicrobial resistance in pig farming are based on the goal of reducing antibiotic use through improving pig health and reducing disease levels. And I'm going to speak about some of the tools they use to try and achieve these goals, particularly vaccination, biosecurity, and diagnostics. Action 1, vaccination. In recent years, the availability of bacterial and viral vaccines has increased significantly for use in pigs. In addition, we use autogenous vaccines and some vaccines under special license. As well as the traditional route of delivering vaccines by intramuscular and subcutaneous injection, innovation has led to the availability of needle-free vaccination through both intradermal vaccination and oral vaccination. These advances have led to a significant increase in the use of vaccines in the pig industry, where there was already a high uptake. Action 2. Biosecurity measures are practices used to reduce the introduction and spread of infectious disease agents. Through the Animal Health Ireland's Pig Health Scheme, pig farmers can avail of an annual biocheck biosecurity audit carried out by a trained pig vet. I advise farmers to minimise mixing of groups of pigs, or in COVID speak, to keep pigs in their pods. I also recommend providing adequate space to pigs, or to allow pigs to social distance. Hygiene has always been and will continue to be a fundamental part of a good biosecurity programme, and it's something that pig farmers focus on. So prevention is better than cure, but despite best efforts, there will always be some disease outbreaks. And when this occurs, making a correct diagnosis is a starting point to dealing with it. And diagnostics are vital in this regard. So Action 3, diagnostics. I use laboratory tests regularly to assist in making a diagnosis, and antibiograms to help select the appropriate antibiotic for treatment where required. As a pig vet, I practice population medicine, and over time develop herd health databases for the farms I work with. This data is very useful to develop targeted disease prevention and control programs, and also targeted antibiotic treatment programs where this is necessary. Actions to address antimicrobial resistance on pig farms focuses on certain categories of antibiotics. Those that the European Medicine Agency defines as Category B, restrict use in animals, and which DAFM refers to as highest priority, critically important antibiotics, Category 2. These are the quinolones, third and fourth generation cephalosporins, and polymyxins. I'd now like to present some data of the trends in prescribing of these antibiotics in recent trends in the veterinary practice I work in. First, the quinolones. We use fluoroquinolones, licensed for pigs, enrofloxacin and marbofloxacin. You'll see the trend was fairly flat through the second half of 2021 and into January 2022, and since then there's been a significant drop. For the third and fourth generation cephalosporins, which ceftiofur is the only one used in pigs, the trend is fairly similar, reasonably flat, and then a significant reduction. These reductions have been driven by the implementation of new EU veterinary medicine regulations in January 2022. The third family, the polymyxins, the antibiotic in this group available to us for use in pigs is colistin, and after a voluntary ban by the pharmaceutical company producing the main brand of this, there'd been a voluntary, effectively, ban on this use, and I haven't prescribed this antibiotic for several years. In my role as a vet, a pig vet, I need to practice teamwork, but also balance. I need to work as a team with the my pig farmer clients, such as Roy, who's going to speak next. I need to work as a team with DAFM, who, while they are regulators, also provide a valuable support to me in my job. We're all on the One Health team, and I'm very aware of my responsibilities in this regard. So to fulfill my role as a vet, I need to practice teamwork, but I need also to have balance. I must never forget as a vet that my primary responsibility is to protect the health and welfare of the animals under my care, and this will always necessitate the use of some antibiotics. The question is how much? But I would suggest as much as is necessary and as little as possible. On that note, I'd like to hand over to Roy. Thank you.
Thanks very much, Paul. And maybe just to underline Paul's reference to colistin. That was a decision taken by the Animal Health Implementation Committee that as a sector, the animal health sector agreed to cease using colistin because they recognised its importance in public health, and in particular in Ireland, its reliance in the treatment of cystic fibrosis. So it was very much taken in the One Health concept. So just to quickly introduce our next speaker, he probably needs no introduction in the animal health sector. Mr. Roy Gallie is a pig farmer from County Kildare. He has a unit with 180 sows. And I suppose for the last 40 years he's been pneumonia-free, which obviously is a very positive outcome, because pneumonia is a very common challenge in the pig sector. He has removed all his in-feed antibiotics from pig rations in 2018, and this is a really significant achievement. And just to mention, Simon also referenced benchmarking. We launched a pig AMU database in 2019 to collect usage data at farm level across all our pig farms. And we have seen this year, 2022, very much a positive trend emerging of reduced use in the pig sector. So I'd just like to welcome Roy to come up on stage and give us an insight into how he operates his business.
Thank you, Caroline, and thank you all. Now, we'll get this thing working here. Can I start by sort of saying that the difference between a pig and a human, so the saying goes, is simply the skin. I'll allow you to make your own judgment later on when you see a few of the photographs. But I'm going to go back to first principles, and it's very similar to COVID advice we are now so used to hearing. In the 1980s, I depopulated my pig farm, washed it from top to bottom, and repopulated with disease-free pigs, so eliminating some of the old-school bugs like dysentery, pneumonia, and mange. As you can see, surrounded by trees and at the centre of a tillage crop, self-isolation has been the key to the farm remaining disease-free ever since. Now, in the 1980s, we farmed pigs like this. But alas, with Ireland's rainfall and its soil type, that type of production system could not exist. So, to produce the numbers of pigs that are necessary to feed us all, we are commercially confined to indoor pig production, with its necessary stocking rates and lack of social distancing, and for a pig, face masks are not an option. In the old school, I'll go back to that one, it's a nice photograph to have up. In the old school of thinking, it was good practice to feed some antibiotics to the piglets in the feed, especially over the weaning period, to help them over this stressful life event. Having heard from my father about his experience in World War II and the introduction of penicillin, the wonder drug curing heretofore untreatable war wounds, followed in my lifetime by multi-resistant bacteria, I've always had an interest in this subject. This interest was fired up further listening to my nutritionist a number of years ago talking about gut microbiome and AMR and the need to move to antibiotic minimization in pig farming. So I decided with Paul and he to take a calculated leap of faith and remove all antibiotics from all pig feed. The result has been evolving over the 5 years since, and I can say ups and downs are both part of it. In the short time we have here today, I want to concentrate on a few of the core practical principles involved in getting pigs from sow-dependent to independent in as healthy a condition as possible, because this is where most AMR stems to at pig farming level. So we'll go back to that one. Now, first one, and Paul alluded to this earlier on, vaccination. Here we are, back to COVID all over again. And it's great to be able to have COVID as a sort of, as an example of bringing all these terminologies which have been part of our lives for the last 15 years. So we've got a full program of initial sow vaccination followed by boosters, timed to protect her, but more importantly, to boost her immune system so that her colostrum will pass on the maximum level of antibodies to her piglets. One of the vaccines we use is an autogenous one grown specifically from samples taken on our farm, covering E. coli, Clostridium, and porcine rotavirus. Then we also use commercial vaccines to protect against erysipelas, parvovirus, swine flu, and porcine circovirus. Cleanliness, which I am told is next to godliness. The maternity pens in our farm are all pressure washed and left to dry for 3 to 4 days before the sows come into farrow. I don't use antibiotics, just a thorough wash and a dry. Actually, I think that's the wrong photograph, but never mind. Doesn't matter. That was meant to be for colostrum. So colostrum intake at birth is critically important. Priming the piglet with energy from an AMR perspective, priming the small piglet with as full a range of farm antibiotics as possible. With the modern sow producing more piglets than teats are available, this can be a problem. But we do our best by split suckling over the first 12 hours so that each piglet has the best chance to get the best intake. Now, where are we here? The gradual move from sow's milk to solid food is a significant event in the piglet's life. We manufacture all creep feed on the farm with some homegrown cereals and premixes of purchased cooked products as per the recipes you see here. This move for the piglet takes time and happens over a period from 3 to 5 weeks of age. Needless to say, the quicker the piglet's gut and his gut microbiome develops, the quicker and better is the transition from solid food in preparation for weaning off the sow. Little and often is best, with some farmers using a porridge. The more conscientiously the creep is given, the greater the intake will be. If a piglet is fully converted to solid food before it is weaned from the sow, the better the piglet continues to grow after weaning. So attention to detail here and to this conversion is very important, so that the check to the piglet's immune system is minimal. And stress, as we all know, is not good for the immune system. Followed by that, there's piglet, sorry, for that, weaning. Right, weaning is a fairly stressful event for the piglet, and it does actually involve a bit of mixing as well, so there's more stress. But we provide a clean, dry, and warm house for the piglets to move into on an all-in, all-out regime. Familiar feed from familiar feeders, clean water from familiar drinkers, all help to minimize the stress. Very like ourselves, piglets have to develop their own immune system and their own gut microbiome. So combined with good sleep, these are these are some of the fundamentals to a healthy life. As farmers, it is our job to promote this to the best of our ability with our livestock. However, this is often easier said than done. Just like COVID, failure to do so will unfortunately lead to higher mortality, a situation we all wish to avoid, be it ourselves or our animals. All of the above practices, just see where we are, there we are. All of the above practices are labor-intensive, so pig farming needs passionate and dedicated staff, which I can tell you at the moment is quite hard to find, as you can all appreciate. Finally, genetics. And I couldn't resist putting this photograph in, which was sent to me a number of years ago. More mouths to feed, more developed countries eating more meat, more scientific research, and the greater use of genomics in breeding programs play a critical role in AMR. As with dogs, the purebreds are highly sensitive and prone to all sorts of ailments. The same too with pigs. And the difference between purebred piglet and a crossbred one is enormous. The vitality at birth and the instinct to go for colostrum are poles apart. The will to live and hardiness of different breeding lines are starkly different. The goal for numbers born per sow, as the main driver of genetic improvement, has left some of the traits of hardiness, survivability, and the related immune system well behind in some breed lines. The financial returns to agriculture must promote best cost food production and focused, as we are today, on reducing AMR, not least cost food production. and focuses, as is the current model. Earlier on, I think Simon put up the farm to fork strategy. I also maintain there should be a fork to farm strategy to make sure that the models that we want to use are commercially viable. Rearing pigs using no antibiotics is challenging, with the disease outbreaks get hold like E. coli in very young piglets. Like COVID, we are now relying on the immune system and best practice to replace antibiotics in our drive to minimize AMR. Now, I just want to move, and I'm taking a little bit sideways on this one because I have the stage here, and I want to draw your attention to the global pandemic of African swine fever. And we were talking about a whole world approach, and while we were all dealing with COVID, well before that, we in the pig world were dealing with African swine fever and the catastrophic consequences of one case of it in this country. These photographs were taken when I was hiking in Romania, and you can see Dracula's castle, and on the right you can see a rather nice little mountain refuge that we stayed in. Beside it, down bottom right, you can see where the shower was, and underneath the shower was a pool of water which the pigs from the forest thought was brilliant. My knowledge was what prevented us bringing back African swine fever to this country. And I believe we have, now that travel has opened up, we need to ramp up the awareness campaign on this dreadful disease. Pat Kerwin, a fellow vet, was in Rio de Janeiro yesterday or the day before, and the number one item on the agenda is African swine fever. This is a global pandemic that, God forbid, it comes to this country, and that is why this country, as an all-island country, must do everything it possibly can to make sure this disease never crosses the Irish Sea. Thank you very much indeed.
Thanks very much, Roy. And now we're just going to move into our last section in this session, which is the environment session. And I'm delighted to welcome Professor Dearbháile Morris, who's the Professor of Antimicrobial Resistance and One Health in the School of Medicine in Galway. She's also Director of the Rhine Institute Centre for One Health at the same university. And her research focuses on antimicrobial resistance, food and waterborne pathogens, emerging contaminants, and the wider societal impact of infection and One Health. Dearbháile is currently leading a number of research projects, one in particular, ARREST and the PEER project, of which there's been a number of papers published, and they have been shared with us at our own Animal Health Implementation Committee by the EPA. And it's also important to acknowledge, and I think Martin did too, that the EPA have been there from the very beginning with us on this iNap journey. So the work that Dearbháile is going to present today was done by herself and 3 other researchers. It was commissioned by the EPA as we moved into iNap 2. And I suppose this work was just to examine the knowledge gaps and the research priorities to improve our understanding of AMR and the role of the environment in its development and spread. So thanks very much, Dearbháile.
Good afternoon, everyone, and thank you, Caroline, and thank you to the organisers for giving me the opportunity to speak to you today on the environmental dimension of antimicrobial resistance. As everybody is aware, following on from the publication of the Global Action Plan on Antimicrobial Resistance, the European Union and many member states adopted their own action plans, including Ireland, and with the subsequent publication of our second revision of our National Action Plan in November of last year. It's recognised in many of these documents and the revisions to these documents that the environment is the part of the One Health paradigm that hasn't received as much attention to date. So in October 2020, the EPA approached myself, Finola Leonard, who's in the audience, and Fiona Walsh, to carry out a research gap analysis to understand better the major gaps in our knowledge in understanding the environmental dimension of antimicrobial resistance in Ireland. And this document and this report is available on the EPA website. So the aims of this gap analysis were to complete a comprehensive review of previous research conducted in the area of antimicrobial resistance and the environment between 2015 and 2021, to identify the key knowledge gaps in the environmental dimension of antimicrobial resistance by carrying out a survey and completing a stakeholder workshop, and finally to identify the key research gaps and to prioritise these. So the process we took to completing this gap analysis was that we completed a review of the national research that was published between 2015 and 2021. We looked at the key knowledge gaps that were identified worldwide. We had the opportunity to carry out a poll at the EPA, HSE and ESRI Health and Wellbeing Conference that took place in November 2020. We circulated a survey on antimicrobial resistance on the environment to key researchers in the area, and finally we held a stakeholder workshop. And all of this process led to us identifying the key knowledge gaps in this area. So in terms of completing the review of national research, the process we took to doing this was that we contacted the national and international funding agencies, and we asked them to give us a list of research projects that were completed in the area of antimicrobial resistance. That gave us a database of PIs, so we searched the relevant publication databases for publications in the area of antimicrobial resistance between 2015 and 2021. And we limited the research search, or the publication search, to that time period. So we acknowledge that there was research carried out in this area prior to 2015, and there is ongoing research that I'll mention briefly in this area also, but we limited it to that time period. So the key findings, and obviously I don't have time today to go into all of the intricacies of these studies, but some of the key findings we found during that research, or the review of this national research, included the fact that antimicrobial resistant bacteria and resistance genes, including CPE, have been detected in human wastewater in Ireland, that hospital effluents are a major contributor of some resistances, but they're not the main driver of antimicrobial resistances in all municipal waters. Wastewater treatment processes reduce but do not eliminate antimicrobial resistant bacteria and genes from entering the environment. And surface waters and groundwaters have the potential to act as antimicrobial resistant reservoirs, and streams and bathing waters may represent an important role in the dissemination throughout the aquatic environment. Antimicrobial residues can persist following wastewater treatment in sewage sludges and in final effluents, and there's very little currently known about antimicrobial residues in waters. There is ongoing research, as I mentioned, and we have an entire list of the current ongoing research projects available in the published report. But some of this research relates to identifying the sources, hotspots, drivers and transmission of antimicrobials and antimicrobial resistance contaminants in the environment. They are looking at the impact of antimicrobials and antimicrobial resistant contaminants in the environment, looking at developing detection tools for use on site, and looking at risk management protocols. And as I said, there's a list and links to all of the project databases available in the report. So we're looking at the knowledge gaps worldwide. There was an excellent gap analysis conducted by Joachim Larsson and his colleagues in 2018. And we adopted the same approach that that group took in developing our gap analysis specifically for Ireland. So the key research needs that were identified in this process, it was funded under Horizon 2020, involved again circulation of a survey and a key stakeholder workshop. And they found that there's a need for the sources of antimicrobial resistance and how the sources contribute to the development and spread of antimicrobial resistance and antimicrobial contaminants in the environment, that we need to develop standardised methods and a harmonised approach to looking at the different sectors, both in the animal health, human health and in the environment. That there's a need to better understand the role of the environment and the impact of anthropogenic pollution on the evolution of antimicrobial resistance within the environment. There's a need to better understand the impact of exposure to antimicrobial resistance through different environmental compartments, and there's a need to develop effective interventions. So we had the opportunity to conduct a poll at the EPA, ESRI and HSE conference, Health and Wellbeing Conference in November 2020, And we essentially used the findings of Larson's research gap analysis to ask the question of the attendees as to which of these 4 areas they felt was least understood or was most important to carry out research in. There was 272 delegates at that conference across a range of sectors, and the 2 areas that were identified as particularly important were the need to better understand the human health impact of exposure to antimicrobial resistance in different environmental compartments, and to develop effective interventions, including behavioural, economic and technological interventions to mitigate the risk. So we then developed a survey that we circulated to key researchers throughout Ireland, and the aim of this survey was to identify knowledge gaps in relation to the sources, reservoirs and transmission routes of antimicrobial resistance, the human, animal and environmental impact of antimicrobial resistance, the role of the environment in the evolution of antimicrobial resistance, and effective interventions to mitigate risk. So we distributed this to 78 researchers throughout Ireland. We just got 22 responses, which was somewhat disappointing, but may reflect the number of people working in this area in Ireland at the current time. 15 of the respondents indicated that they have been involved in research relating to AMR in the environment in the last 5 years, and 14 of those indicated that they had received funding for this research from the agencies listed in the figure on the right. We then asked them a series of about 20 questions covering the 4 areas I indicated earlier. So and we asked them to rank in terms of what they felt was the least investigated to date and what was the most investigated to date. So in terms of ranking the sources of antimicrobial resistance in the environment, the respondents indicated that the wildlife was the least investigated to date, whereas humans were the most investigated to date. In terms of ranking the environmental reservoirs of antimicrobial resistance, the respondents indicated that plants, non-edible to humans and animals, were the least investigated to date, whereas fresh waters, both surface and groundwaters, were the most investigated to date. In terms of understanding the role of the environment in the natural evolution of antimicrobial resistance, 73% of respondents indicated that they believe the natural environment is the original source of many of the resistances that are causing us a problem in human healthcare and in animal pathogens. That there's a need to better understand the evolution of antimicrobial resistance from source to the final receptor. There's a need to better understand the drivers of antimicrobial selection and persistence in the environment. And there's a need to better understand the role of gene sharing in the evolution of these pathogens. When we looked at the effective interventions to mitigate risk, the respondents indicated that behavioural interventions were the least investigated to date, and economic interventions were the most investigated to date. Looking at the transmission of antimicrobial resistance between the environment, animals and humans, when we look at transmission between environment and humans, respondents indicated that transmission between air and humans was the least investigated to date, and transmission between freshwater and humans was the most investigated to date. And similarly, between the environment and animals, it was the same findings. When we look at transmission within the environment, the respondents indicated that transmission between air and seawater was the least investigated to date, whereas transmission between freshwater and soil was the most investigated to date. When we look at the human, animal and environmental health impact of exposure to antimicrobial resistance in different environmental compartments, the respondents indicated that the risk of disruption to the natural biodiversity in the environment was the least investigated, whereas the risk of infection with antimicrobial resistant organisms for humans was the most investigated. So all of us then led us to the key stakeholder workshop. We invited 38 key researchers and stakeholders to attend, 28 of which did attend from the institutes listed there. And it was broken down to 3 compartments: an introductory session, 3 breakout sessions, and a closing session. So through each of the 3 breakout sessions, the groups were given the opportunity to discuss each of the topics on rotation, looking at the understanding of the emergence and transmission routes of antimicrobial resistance to or from the environment, the impact of exposure to antimicrobial resistance in different environmental compartments, and reduction in risk assessment. So all of that process then led us to identify the key research priorities, which we divided into areas of high priority, medium priority, and low priority. So the high priority areas are those that are little or no knowledge currently available in Ireland. So we found that we need to better understand the impact of of exposure to antimicrobial resistance and antimicrobials through aquatic environments on human and animal health. And the key to this is to develop standardised protocols to carry out the surveillance, and also this will help us to develop appropriate risk management strategies. That we need to carry out a nationwide analysis of antimicrobial resistance and antimicrobials in soil and plant environments to generate or to bridge gaps in the data that's present in those areas. We need to carry out research into potential solutions to mitigate against the transfer of antimicrobial resistance and antimicrobials from human and animal sources to aquatic and terrestrial environments. We need to analyse the roles of waste from sources not studied to date, such as wildlife, companion animals, abattoirs and pharmaceutical industries. We need to carry out research into the role of the natural environment as a source and sink for antimicrobial resistance genes and understand better the natural evolution of these genes and organisms within the environment. We need to analyse the impact of climate change on the dynamics of antimicrobial resistance in the environment and analyse the importance of air as a transmission route. The medium priorities identified are those that have limited knowledge available in Ireland, and one of the key ones here was to develop standard and rapid methodologies for sample collection and reporting, and this will allow for sharing of data across the sectors. And we need to understand better the role of the environment as a transmission and dissemination route for antimicrobial resistance. The low priorities then are those that currently lack enough data to be able to develop these aspects, and these include the need to examine and implement behavioural interventions through enhanced communication, to develop and implement guidelines relating to appropriate management and surveillance of wastewater's effluents and their receiving environments, to improve wastewater treatment processes, develop a centralised knowledge database, which again will be based on developing a harmonised approach to surveillance, and the creation of risk assessment models of antimicrobial resistance transfer to the environment once there is sufficient data available. So finally, I'd just like to thank my co-authors, Niamh Cahill, Finola Leonard, Fiona Walsh, those that responded to the survey, those that participated and facilitated the workshop, and the EPA for funding it. Thank you.
Thanks very much, Dearbháile, and for all the work that went into that document. I think it'll be a really useful tool to inform future research. And I might just add that as of last year, the department is carrying out surveillance on over 20,000 farms, taking soil and looking for the presence of ESBL E. coli. So we're doing that work at the moment. So then we're at our last speaker before lunch. And I'd like to welcome from Cork, Dr. Jean O'Dwyer. Jean is currently Deputy Head of Environmental Science at UCC and Deputy Director of the Science Foundation Ireland Research Centre for Applied Geoscience. And today, Jean will discuss research focusing on groundwater, and I think we've already been mentioned both by Dearbháile and Simon the importance of clean water. So Jean will discuss groundwater and its potential risk to public health, and I suspect she will probably emphasise the importance of a One Health approach to water quality. Thanks, Jean.
Right, hi everyone. So I'm acutely aware that I'm the only thing between you and a hot lunch, so I'll try and keep this as quick as possible and as interesting as possible. So everything today has been a bit broad, and as it should be because it's a very broad issue, I'm going to bring it quite specific, oddly specific almost, focusing on groundwater. So the title is From the Water Table to the Kitchen Table, and I'm going to talk a bit about my own research in this area. So a very valid question is why groundwater? So we're in Dublin City at the moment, which is served by the public water supply, but outside the city areas, in rural areas, there's a very high reliance on groundwater. And if we move outside of Ireland, that's even higher. So if we look at it globally, 2.2 billion people are reliant on groundwater as their drinking water supply. And in Ireland alone, it's about 750,000 people that are reliant on groundwater for their drinking water resource. The problem here, so when we think about drinking water, most of us don't really think about it, but when we move into the groundwater realm, a kind of problem develops. And that is that people who are extracting groundwater in Ireland through private wells, etc., they are not covered by the European Drinking Water Directive. Right? So there's no legislation surrounding the quality of that water. If it serves less than 50 persons, it's not covered by the legislation. So this water then means it's been consumed largely without any treatment whatsoever. And as you can imagine, if things go awry, this can lead to issues. In Ireland anyway, from our own research, we know that groundwater supplies can be quite susceptible to contamination through the source pathway receptor phenomenon, where we have a high reliance on agriculture, we have a lot of septic tanks, we have a lot of source of bacteria in the environment. We also have this kind of odd geology across the country where it's very varied and heterogeneous. And this means that we can get potentially pathogens in groundwater. And for people that are familiar with it, we have an infectious disease in Ireland called virotoxigenic E. coli, VTEC. We have the high incidence rate of this in Europe. And we've shown in research that private well usage is very much associated with this infection. So private well users are almost 19 times more likely to catch this waterborne disease than non-private well users. Right, so the health link is there already. So then, Joe, the thought kind of pops up, will antimicrobial resistance be a problem? So to start, I'm going to look at this at a global perspective, right, because this is a big challenge. Joe, it has obviously global impacts. And we did a study looking at doing a systematic review to see across the research, Joe, was this actually something that we should lose a bit of a night's sleep about? And as you could probably guess, unfortunately, it kind of is. So this is all the studies mapped here. As you can imagine, the red is a bit more ominous. So this is where you have higher levels of resistance, and green there is not bad. Okay, considering the importance of groundwater as a drinking water resource, and considering the actual amount of people using it, there's surprisingly little research actually being done on it. And that's because, as Dearbháile kind of alluded, the environmental dimensions of AMR are only kind of creeping in the last number of years. But if we look here, we can see that in places like Africa, we get very high resistance. The size of the bubble there is relative to the amount of studies. And you'll see in Ireland, which I'll talk about in a moment, we've only one or a couple of studies now to date. And you'll see there we're that lovely shade of red in the kind of worrying areas. So in this review, which is published in Water Research, we have 70 studies that were included. And the takeaway message from it, I suppose, was where bacteria was in groundwater, 80% of them were resistant to antibiotics, and 57% of them were multi-drug resistant. This is the water that people are drinking. A, now it's contaminated with bacteria, and B, these bacteria are resistant to antibiotics. So we have a bit of an issue. To bring it back to our own little country, looking at it in Ireland, we've done a lot of research in this area, and one in particular was one that I did back in 2018 using isolates that were collected a couple of years before that. So I had E. coli isolates sitting in a freezer in my lab, and then in 2018 I was a bit bored. I said, for a bit of fun, I'll start doing some antimicrobial susceptibility testing on the isolates, which gives you a bit of insight into my social life. But aside from that, so we digged them out of the freezer, and we tested them against a panel of specifically human and specifically veterinary antibiotics. And there were some interesting findings. So this is in the Midwest region, Limerick, Clare, Tipperary, which is a bit of an anomaly in terms of infectious diseases and things like that as well, because it does have a lot of agriculture. It has a bit of a unique hydrogeological profile, so movement through the environment of contaminants is a bit easier. Okay? So what we found here, and I won't labour on them, but looking at the human antibiotics only, about 20% of the isolates were resistant to a human antibiotic. The highest levels were associated with things like penicillin, Joe, which is no surprise to anybody really. So the human antibiotics, Joe, I raised my eyebrow, but I wasn't overly concerned about it. The veterinary ones, though, were a bit of a different story. So we had a panel of veterinary antibiotics, and every single one of those isolates was resistant to at least one of them. So we had very, very high levels of resistance to these antibiotics, with aminoglycosides showing up as an issue, and things like tetracycline and the fluoroquinolones also popping up for E. coli isolates that were resistant. We're going full science here now, right, but I'll block things out for you. We wanted to see if any risk factor, if we could link any risk factors to the development of resistance within these isolates. So this is looking at antibiotic resistance and multi-antibiotic resistance for the human ones. And I'll just block out here anything that didn't really play a role in development. So again, for the human ones, what's interesting is we found a statistical association between septic tanks and the development of resistance and multiple antibiotic resistance of these isolates. We also found that for children less than 5, if children were less than 5 or in the household, you were more likely to have antibiotic resistance E. coli in the water supply. So this is backed up by findings. We've seen associations between septic tanks and resistance before, and children tend to have more antibiotics prescribed to them, be it through just getting different infections or over-anxious parents, whatever it might be. So an interesting kind of tale where we see this direct link between usage and development of resistance. For the veterinary antibiotics, they were so resistant to things we couldn't look at just resistance. We had to look at multiple antibiotic resistance because there was no control group otherwise. And here it was interesting that the only thing that came out was cattle density. So if there was a higher number of cattle in the area, you were more likely to have resistance to different antibiotics. Okay? So this again is kind of supported by other studies. We know through the One Health programme these links between the environment, agriculture, humans, all of it coming together. I'm not pointing fingers at anyone, but we know that the environment and water and people, they're all intrinsically linked. So to take it a bit further, we decided to model it, and all this really means is can we predict, right? Because we want to be able to predict things so we don't have to go out sampling everything. And if we're looking here at the human panel, what we can say after this is that resistance to E. coli to human antibiotics increases by a factor of 1.01 for every septic tank in the area. You might go, Jean, get a grip, that's nothing, 1.01, but the difference between two areas is never going to be one septic tank. It could be 10, it could be 50, it could be whatever, okay? We also found that if you had a child in the house less than 5, you were almost 12 times more likely to have resistance to antibiotics if E. coli was in your groundwater. And then for the veterinary panel, we found that for every increase in one cow, it also increased your odds by 1.001 of having a bacteria that was resistant to veterinary antibiotics. Again, a very small number, but the difference between two areas is never a cow, it's multiple cows. So it's incredibly important. As I said, this is a bit of a back-of-the-envelope study, that I sadly did in my spare time, but it was the precursor to getting funding to actually do a better study. And the second study was looking at a national perspective, and this is funded by Science Foundation Ireland. So in this study, we did 132 private wells all over the country. We tried to get as many counties in as possible. I think we got all 26, actually. It was my PhD student who did most of this work. There were 16,000 kilometres of driving involved in this, taking all these water samples from people's homes. I think people forget that. Twice. We did antimicrobial susceptibility analysis. We also tested for metals to see if there was any link between metals and resistance. And we had all the isolates sequenced, which we're still waiting on. I'm not presenting those results today. Similar story to what I had found all those years ago in 2018. Then we were looking at it across the country. It wasn't as stark. We see the cattle density coming out again for resistance to antibiotics. In a token of good news, I will say that we went out in 2019 and 2021, a bit of this year as well, 2022, and resistance levels were lower in 2021, 2022 than they were in 2019. So be it something with COVID or people weren't going to GPs and getting prescribed antibiotic as much, I'm not sure. There was some difference between them. I might mention as well that this was looking at just 132 wells. In my first study, it was only 42. It's a small number, and it was a one-off sampling regime, in 2 sampling times. But we also work with the EPA looking at the monitoring data. So the EPA has monitoring wells dotted all across the country where they're sampled periodically over a very long period of time. And we looked at the National Monitoring Network for E. coli, and over a 10-year period, and we found that nearly 70% of those monitoring wells have E. coli at least once over that monitoring regime. So that's incredible. So 7 out of 10 of them were contaminated with E. coli at least once, which gives us an indication of potentially how problematic this could be for the country moving forward. So my take-home messages anyway for this is that groundwater contamination in Ireland is a very real and persistent threat to public health, be it through waterborne diseases or now through this exposure to AMR, which is becoming increasingly apparent. I think considering the reliance we have on groundwater, and the fact in Ireland and globally is that safeguarding private well users is now something that should be really heavily prioritised. Right? So the environmental contamination issue is a different problem, but we can protect public health through putting in different systems in people's houses. We need to do more research, okay? So, much more research has to be done of this in Ireland and further afield, looking at the mechanisms, legacy times, sources and the fate of it. And then pragmatically, to bring in the social science aspect that people have mentioned throughout, we need to just talk to people, talk to private well owners, educate them, make sure they understand the risks. Nobody wants E. coli in their bloody tap water. Normally when people are aware of an issue, they tend to take on stewardship themselves and fix it. And then, in order to do that, I suppose, effectively, there has to be some sort of governmental support, infrastructurally or through grant aid, to help them to install treatment systems to protect their own health. So that was a very stopgap tour. So you can corner me at lunch if you want to chat about it, or for anyone watching online, that's my email address. And thanks to the usual funders for supporting it. So thank you all for listening.
Thanks very much, Jean, and sincere thanks to all our 7 presenters we've had in this session. I think lots of food for thought, lots of discussion over lunch. So given that we're 25 minutes behind schedule, I haven't really done my job very well, but I will send you off now to lunch. There's 2 rooms, and if you just exit stage right, and that'll get you there. Thanks very much, everybody, and see you after lunch.